All right. Mic check 1 2 1 2. We're live.
We're on there.
Good evening, everyone, and welcome to another episode of the Cape MD. We are so honored and excited to introduce our guest for the evening. This is our University of Iowa homeboy alumni, at least for Keisha and I, because we went to medical school and he was like all cool and whatnot and already in his residency doing the thing. And we were like still struggling in medical school. But anyways, we're so excited to introduce Dr. Howard Ober. He is a board certified urologist. He went to Morehouse for undergrad. He completed medical school at Meharry. And he did his surgical internship and urology residency at University of Iowa. He's currently practicing in Riverside, California, where he is the co-director of robotic surgery at Riverside Community Hospital. And he's also an assistant clinical professor at the University of California at Riverside. He specializes in robotic cancer surgery for robotic surgery for prostate and kidney conditions. And then he's also medical director of Opal. Am I saying that right? Opal?
Yes.
Nutrients, which is a custom supplement and nutrient company designed to improve the nutritional value in our diet. So we're so excited to have you, Dr. Howard. I want to just start by acknowledging the fact that Al Roker of the is it Today?
I believe, yeah.
Al Roker of Today, recently announced in November that he had prostate cancer, and he was urging men, especially Black men, to make sure that they were taking the necessary preventative measures. And so I want to start by just kind of opening up there, Dr. Howard, about Al Roker's willingness to share with the world about his recent diagnosis of prostate cancer.
Yeah, it was very, I think, courageous of Mr. Roker to come out publicly with some information about prostate cancer. This is something that's affected a few different celebrities in the past. Most notably, Ben Stiller was diagnosed with prostate cancer 3 or 4 years ago. But there's never been anyone in the African American or minority community that's come out and kind of been very aggressive at saying, hey, this is something that affects us. This is something that, we should make sure that we get checked in on. Additionally, African Americans tend to be at a little higher risk. So I was really, really pleased that he came out and said, hey, make sure you make time to make this important to you. So really, really excited that someone in our culture actually came out to be more progressive about prostate cancer, both getting checked out and talking about his treatment options as well.
So can you talk a little bit more, tell us a little bit more detail about the differences in prevalence of prostate cancer in African American men versus other populations, and maybe why that might be?
Oh, of course. So just first off, some general statistics. Prostate cancer is still probably the second most common cancer that men are going to get. It affects about 1 in every 9 men in this country. African Americans have a probably 35% higher risk of getting prostate cancer than our white counterparts. And if we talk about risk factors, I don't know, specifically as it refers to African Americans, I mean, family history plays a big part in that. The other big risk factors, what we consider, how can I best put this? Our comfort or soul food, diet loving tendencies. One of the things we know in medicine, especially in urology, is that one of the things that really leads to higher risk of prostate cancer is a diet high in animal protein and fried foods. And that's something, especially around this time of the year, where we're all getting together for those big comfort meals and those big comforting get-togethers, that's a staple of our diet. So have to be really cautious with that stuff.
Wow, I had no idea that diet was that big of a risk factor. What are some of the signs and symptoms that men should be aware of? Like if they're experiencing this or that, they need to go and get checked out by their doctor.
So that's the crazy thing about prostate cancer. These days, we want to find prostate cancer before you have any symptoms. By the time you have symptoms from prostate cancer, it's too late, or your prostate cancer is very, very aggressive and at an advanced stage. Some of those symptoms would be difficulty with urination, blood in the urine, commonly things like back pain or pain in what we call the long bones. So the legs, the shoulder, the legs, the arms, the back, the shoulders. But by the time you have any of those symptoms, that typically means the cancer spread to the bones, and that's why you're having pain. The cancer is invading into the bladder, and that's why you're having blood. Or the prostate's kind of obstructed the urethra, which is why you're having difficulty urinating. The benefit to today's treatment or today's diagnostic evaluation is that, with different blood tests, we find a cancer so much earlier that we find it a much higher curable stage.
I think a big thing that I've realized, even with you saying like it, what we've been eating over the holidays, one of the things that I've heard a lot here lately is, I don't want to eat Thanksgiving food. I eat that all the time. And I'm like, if you eat Thanksgiving food all the time, like I enjoy Thanksgiving food because I get it twice a year, Christmas and Thanksgiving. But if you're eating that type of food all the time, you're putting yourself actually at increased risk of some of these cancers. And
Absolutely.
So what would you tell like young men and women, especially of our community, to eat right now?
I think the big thing is we really have to start looking at our diets and kind of how we feed or how we fuel ourselves. Real funny, quick story. My mom came to visit me a couple weeks ago, and she decided she wanted to make some home food for me. I'm from Louisiana, so she decided she was going to make gumbo. So I was like, all right, all right. And then she started making the gumbo. And for the past couple of years, I've been really interested in being more healthy, pursuing a much more healthy lifestyle, looking at our food and kind of seeing what kind of nutritious value with it. And a gumbo starts with a roux, which is butter and flour, right? So you're taking this processed carb and you're mixing it with this hydrogenated fat, okay? Then you mix in a bunch of red meat. maybe some shrimp or seafood. My mom bought turkey necks. And I'm looking at the base and the stuff is all mixing and boiling together. And I'm like, this is the most unhealthy thing that you could ever consume. And so I started saying, like, what can we do to this gumbo to make it better? I'm like, can we put mushrooms in this? Can we put spinach in it? Can we put kale in it? Can we put broccoli in it? Can we California this gumbo a little bit?
Dr. Howard, you cannot kill the gumbo.
Not kale in the
times
gumbo.
a year. You can eat this once or twice a year. That's it.
Not California, the gumbo.
No kale.
That is California gumbo. Next year they're gonna try and add some avocado.
I've been in California too long.
Ladies, I'm having some technical difficulties.
Oh,
Can
no
you hear me?
problem. Yeah, we can hear you.
Mm-hmm.
I can't hear anything.
Can you hear us at all now?
You guys can hear me, right?
Yeah, we can hear you.
Uh-oh, he just lost him.
That's okay. Maybe.
Y'all said California gumbo. Y'all are silly.
That's what.
That's that vegan.
Kale to the gumbo.
I lived in California for a year. They put kale and avocado in everything.
No kale in the gumbo.
How is that, Dr.
Hello?
Can you hear us okay?
Oh no. All right, let me see.
Keisha keeps freezing.
I'm so sorry, ladies. I can't figure out what's going on.
No, it's okay. I'm just looking through my settings too, just to see if there's anything.
1 second, please. Hello, can you guys hear me at all?
Yeah, we can hear you. Can you hear us? Yeah, we can hear us.
All right, I'm back.
Awesome.
Yay! So we've been having Dr. Howard, we've been having a good laugh. Like, oh, he tried to create California style gumbo with kale and avocado and mushrooms. We're like, Dr. Howard's trying to ruin the gumbo.
I mean, ruin the gumbo, but not ruin my health. You know?
True that, right?
Good point.
It is what it is. I mean, the other thing is, I went back home for a funeral, and you know, I look at the rates of obesity in the community, and it was kind of astonishing. I looked around at my family members, and I was like, God, what can I do? And basically, that's where that healthy version of gumbo came into mind. I was like, is there a way that I can switch this up so that we can still enjoy the foods that we're used to enjoying, but just kind of bring a little bit more nutritious value to it? And that's all it was.
Nothing wrong with that.
That was my thought anyway.
Dr. Howard, what did your mom say? What did Mama have to say about your commentary to her gumbo?
She was not pleased. She was not pleased. And I think she was kind of offended. She was like, I'm coming here to cook you some comfort food and you try to California me.
You said it too.
I took a moment. I was like, you know what? You're right. I should just sit here and just eat this the way you make it and make some revisions. And next time you come, I'll cook it for you my way and we'll see what happens.
Right.
So
there you go. Well, since we've talked a little bit about the risk factors and also a little bit about potential signs and symptoms, which we're hoping people get diagnosed before it gets to that point. So at what point should men start getting screened for prostate cancer?
All right, so this has been a point of contention for a few years. I think 3 or 4 years ago, there was a lot of controversy about PSA screening. As you ladies know, PSA stands for prostate specific antigen. It's a blood test that we use to screen for prostate cancer. And the reason that there was a lot of controversy is because maybe a decade, 10, 15 years ago, they were checking PSAs and they were finding a lot of very low grade prostate cancer in a lot of people, and they were treating everybody, curing everybody. The problem is in prostate cancer, there's no perfect treatment option. So whenever you treat someone, there are side effects, most notably urinary leakage for a period of time, erectile dysfunction for a period of time. And those guys, once their cancers were cured, 5, 10 years down the line, they're still having trouble with urinary leakage. They're still having problems with erectile dysfunction, and they weren't very happy. And so they looked at the numbers and they said, we really aren't curing anybody, or not. We're not preventing anybody from dying from prostate cancer because we're finding all these very low grade cancers. And so there's controversy saying, well, maybe we shouldn't be checking PSAs. Well, then it flipped the other way. We stopped checking PSAs, and then people started coming in with very advanced and aggressive prostate cancer. So people were coming in at stages where we couldn't really cure them in time. So now we have a lot of patients that we could treat, but not as many people that we're curing. And so now we're in that middle stage of trying to figure out who exactly do we screen and what time, when do we start screening them? So generally, we don't recommend screening for anyone under the age of 40. So no person. So if you're under 40, you don't have to get screened at all. If you are African American, or if you have a family history of prostate cancer, so someone like a dad, a brother, an uncle, a grandfather, we recommend that you get a baseline or a very first PSA at 40. And then if that's normal, about every 2 years, get another one. And what we're doing is we're checking the trend and the rise over time. So if your PSA this year is, let's say, 2.0, and in 2 years it's 2.2, in another 2 years it's 2.4, that's perfect. But if this year it's 2.0, and in 2 years it's 4, and then the year after that it's 6, then that number is increasing too rapidly, and that's what we consider an aggressive rise. If you're not African American or don't have a family history, we recommend that you start getting your PSAs checked at 55. And you get it checked on a yearly basis from age of 55 to 69. And then if your numbers stay perfect then once you're 70, you really don't have to get them checked anymore, unless your numbers are higher. And if they're higher, then we still kind of recommend you getting them checked on a yearly basis.
Dr. Howard, is there a correlation between BPH and digital rectal exams and prostate cancer?
Not a direct correlation. So think about digital rectal exams. Let's talk about that first. We no longer recommend rectal exams for screening. So this should come as a jump for joy for most guys, because this was one of the things that, people used to really hate. So people would come in the room and the first thing they do is, let me see your hands. And I'm like, because they're always concerned about this rectal exam. And what the research shows is that with the PSA test is so accurate now that it kind of rendered the rectal exam unnecessary. What we found is you would have to do 100 rectal exams to find one person with a normal PSA and an abnormal rectal exam. So, I mean, you're basically saving 99 out of every 100 guys from getting a rectal exam. So we don't routinely recommend rectal exams anymore. As far as BPH is more closely associated with an elevated PSA than it is prostate cancer. You can have both at the same time, but they're not directly correlated. So sometimes we have guys come in with an enlarged prostate symptom, so they're having trouble urinating and frequency and urgency, and we check their PSA and it's elevated. So then we have to do an evaluation or biopsy to rule them out for both. So they're related, but they're not directly correlated, I guess is a good way to put it.
I think that's really good. It's interesting that you talked about, like, let me see your hands. Patients tell me all the time, especially my African American male patients, say, one, I chose you because when you went to HBCU, Morehouse Spelman, spell house in the house.
And
two, because I'm a woman, so I have small hands. And so what I told them is the urologists I've known in Indianapolis have told me the exact same thing that Dr. Howard is telling you guys, which is we don't do digital rectal exams anymore. I still do PSAs on all my men, but I don't do a digital rectal exam anymore. And that was a big thing. I mean, for a while, like, men would be like, no, you're not touching me. No, there was a huge stigma to the digital rectal exam. Like, men were like, you're not going to stick your finger in my behind. Like, no way.
Yeah. It's a masculinity thing. It's a demasculation thing, in theory. But I always tell people, I mean, at the end of the day, you're doing this to evaluate and rule yourself out for prostate cancer.
Exactly.
Because you are the guy, I'll say this, but you have to take responsibility for your family. You need to make plans to be there. And if it takes, a rectal exam takes me 3 seconds. I mean, that's it. Like, I hate doing rectal exams. Like, I've got a sign up on my wall. Like, back when we were still doing them, I got a sign up on my wall, and it has a doctor, and he's got a pole with a hand with a glove on it at the end of the pole. I'd be like, if I could do your rectal exam with somebody else's finger, that's the way I'd rather do it.
Yep.
You know, for some reason they come in and think that it's my favorite thing in the world to do, and I'm like, no, man, I'd rather you keep your pants on the whole time if it was up to me. I love the blood test. It's made my life a lot easier.
Yes.
Yeah, like I remember certain days of med school very vividly, and having to learn to do a rectal exam is one of them.
Absolutely.
PTSD.
Right. So we're all excited about that news, Dr. Howard.
Of course, of course.
Dr. Howard, do you find that there's a stigma associated with the diagnosis of prostate cancer? And if so, does that vary amongst cultures?
There is a stigma. Like I mentioned earlier, there's always side effects to prostate cancer treatment. Treatment nowadays is much better than treatment was 10 years ago. Radiation's much better. It's much more focused and organized. Surgery, especially with robotics and the visualization and magnification, is much better. We get much better results, but you know, you're still not perfect, and it still takes time to get back to normal. So in essence, the side effects from both radiation and robotic surgery is still that you do have continence issues and you do have erectile issues. And it's not so much cultural. I take that back. Some cultures, it's a very big deal. Masculinity and sexual performance in the Hispanic culture is extremely high. And so that's a big deal in that culture. I find that it's a little bit, I find that in the Caucasian and African American cultures, it's more age dependent. Unfortunately for African Americans, we get diagnosed with prostate cancer at a younger age. And so that stigma is more prevalent for us because, you know, if you get diagnosed at a younger age, then you have that issue younger. The benefit, though, is if you get checked early enough, what we do know is that recovery of erectile function, the most important factor about it is what your pre-surgical function was. So if you have surgery when you're younger and you had good function before surgery, you tend to recover that function much better. As if you had minimal or moderate function and you were older, it's harder to get back to where you were before. As a matter of fact, I just had a really good friend, a surgeon friend of mine, African American. He's 51. He was diagnosed with prostate cancer a month ago. He had his surgery yesterday. And he and I had a very candid talk about the stigmas and all the issues that come with it, and you know what he should go and do before surgery. And we had a very candid conversation, and I'm glad he was able to kind of come and talk to me about it. But this is one of those things where you get this, and all of a sudden, you know, the first 2 weeks, as with almost any cancer diagnosis, I mean, guys, you're looking at it through glazed glasses. You know, everything's just going through. You're not really processing the information, so it can be hard to bring it all together. So there is a stigma. So to answer your question, yes, there is a stigma. Yes, it can be cultural. It's age dependent a lot of times as well.
I think a good thing for patients and people to know out there is like, how should you advocate for yourself? We know we don't do digital rectal exams anymore, but there's a lot of even physicians who aren't doing PSAs as much anymore. How, as African Americans and men in general, what should they advocate for themselves when they go to their primary care docs?
I mean, as a guy, you should know what you should be getting checked out for. You should be getting EKGs, you should be getting colonoscopies, you should be getting PSAs, because at the end of the day, you have to be there to take care of your family. And if you're not taking care of yourself, you can't be there to take care of anyone else. So you have to make your health a priority. so that you can prioritize everything else in your life. And so what we try to do is, you know, put a lot of special attention out there to things guys should be doing. November is a big month for us.
Yes,
Most
it is.
you guys missed it. I had this big gray beard up until like 3 days ago. So I'm so glad.
My husband just cut his off yesterday.
So did I. So I'm so happy November's over with. So I don't look old anymore. But we try to really run a lot of special focus in November that says, hey, these are the things that we need to call men's attention to: prostate cancer, PSA, testicular cancer, testicle self-checks, colonoscopies, getting stool wax or whatever they're doing for all that stuff right now, getting your heart checked, getting EKGs. Because the last thing you want to do is have a sudden heart attack or get diagnosed with late stage cancer of some sort. Because when you do that, you just leave yourself short on options. And that's what we're trying to prevent. As long as you have options, you have a way out, you have potential. But if you don't give yourself time to have options, then there's not much anybody can do.
I think you made a great point earlier too, is if we catch this early and you're younger, we tend to have less side effects. And men instantly think that if I have prostate cancer, I'm instantly not going to be able to have sex anymore. My energy level is going to be super low. And I think it's important for men to know that the sooner we catch this, the better off they will be.
Absolutely. And the other thing, there's one other side of prostate cancer I really didn't mention. Prostate cancer is different in everyone. Some prostate cancer is going to be very low grade, a very mild case. And some patients will have low grade prostate cancer that will never progress or won't progress for several years. And so a prostate cancer diagnosis doesn't really do you any harm unless you have anxiety about it. Some guys are going to have a very aggressive prostate cancer that, needs to be treated immediately. And then you've got everybody in between. So if it's one of those things where if you want to find out, well, you never want to have it. But if you have to have it, you want to find out super early, because getting diagnosed early gives you all the options in the world. And that's what we really want.
So Dr. Howard, you mentioned earlier briefly the different treatment options: radiation versus waiting and watching versus surgery. We mentioned earlier that you specialize in robotic surgery. So can you tell us just in general how you talk to your patients about what their treatment options are?
Absolutely. So there are a number of treatments for prostate cancer. There's some things that are out there in the interwebs that people, the side effects from prostate cancer are something that drives a lot of men to do a lot of wild things. Not wild things, but look for a lot of options. And so there are a lot of options out there that you can find. Things that are not either FDA approved or things that have long been discontinued for some reason. So there's a lot of random stuff out there like cryotherapy, like HIFU therapy, like kind of more experimental things. But at the end of the day, what we found that consistently works both for cancer cure and for a lifestyle improvement over time is going to be surgery and radiation. And there's two types of radiation. There's brachytherapy or seed radiations, where we put small seed implants of radiation into the prostate, and those seed implants give off a low dose of radiation over the course of about 6 months. That's a small 1-hour surgery, same day in and out. The second type of radiation is called external beam radiation. Now, there's been a lot of development in external beam radiation over the past several years. You guys might hear of proton therapy. The big thing with radiation has always been scatter. The prostate is not the only organ in the pelvis. And so the problem with radiation in the past is the prostate sits right in front of the rectum and right underneath the bladder. Well, before, the radiation just goes through, and whatever radiation touches, it kills. And if there was prostate in the way or rectum in the way, it all got, excuse me, got bladder in the way or rectum in the way, it all got a dose of radiation as well. And radiation to the bladder and rectum causes issues as well. So the theory behind proton is they can calculate the radiation dose to hit the prostate and miss everything else. So that's proton. And then there's what they call stereotactic radiation, which is a different algorithm to use neutrons to do the same thing that the protons do. I'm not a radiation expert, just kind of slept at a Holiday Inn last night as far as radiation is concerned. And then we get to surgery. So the advent of the robot and now the new training, the robot is put us in a position where we can do the surgery through very, very small incisions. And with the magnification of the camera, you can get a very, very meticulous and fine dissection around the prostate. One of the scarier things about prostate cancer is the nerves that control the erection come down from the spine, through the sacrum or through the tailbone, around the rectum, and then they literally wrap around the prostate like layers of an onion. And if you've ever tried to peel an onion back, you know, sometimes depending on how fresh the onion is, the layers are easy to peel off or not. And that's kind of how prostate cancer is with the nerves. And so there's this terminology in urology about sparing the nerves. Did you spare my nerves? Can you spare the nerves? Well, sparing the nerves in the prostate is kind of like peeling off layers of an onion. And again, it differs. You know, when you diagnose prostate cancer, you do a biopsy, you take so many samples on the left and so many samples on the right, but everybody's biopsies come back different. Like one guy might come back and all the samples on the right were positive, but all the samples on the left were normal, or vice versa, or they might have more positive at the front of the prostate than at the back. The benefit now is that when we do these surgeries and we know the biopsy results, we can cater the nerve sparing to where the positive part of the prostate cancer is versus the negative. So we can spare more of the nerves where there's no cancer, and we can be more cautious about the nerves or more cautious about the cancer where we know the biopsy was positive. Because the last thing you want to do is spare all the nerves and leave cancer behind. I mean, that you just wasted an operation. So that's what we're doing now. We're trying to customize every patient's surgery according to their biopsy and according to what their prostate looks like, so we can give them a really good result.
I think that's the blessing of the robotics operation now, is that how you characterize kind of where you're going to go, where you're going to start, where your emphasis is going to lie. And that also gives patients an ability to also say, well, they're treating me, the patient, and not the disease.
Right.
Which is a thing that I think as we grow in medicine in general, that's what we're going to go to. You know, that's why we don't do digital rectal exams anymore. You know, we're trying to cater to the patient and the need of that particular patient and not the disease in and of itself. And I think that that's what I try to tell my patients when I'm sending them to a urologist, was like, yes, your PSA is elevated. No, I don't know what that's going to look like 6-7 months from now, but I'm going to tell you that your urologist is going to cater your treatment to your needs and
Right.
not the needs of the disease, which is, I think, super important to where we are in medicine right now.
Yeah, I agree. I think customizing treatment it's what everybody wants. And it gets everybody better results. You know, if you do the same procedure the same way for everyone, it's just going to be, you're not going to get the best results.
True.
So, Dr. Howard, I know we have to save room for questions from our viewers, but I don't know if you watched our show before, but I'd be remiss if I didn't bring some humor to our show. So I know a lot of the guys out there are very curious with respect to what types of wild things they can research with respect to the side effects of prostate cancer surgery. Should nerves not be spared? Would you speak on that a little bit to give some of the guys
should nerves
some hope?
not be spared? The only reason I would tell someone not to spare the nerves is if they came in with a very, very aggressive prostate cancer that looked like it was growing outside of the prostate. We can almost always spare some nerves, but then again, it also depends on anxiety level. Like some patients are like, just get this cancer out of me. I don't care if I never have another erection in my life. I just want to be here. And if that's his MO, then leave the nerves, get the cancer out. You know he won't have any cancer recurrence. He doesn't care about the erections. If it's good enough for him, it's good enough for me.
You skirted around that very nicely. Thank you.
So we actually do have a question from one of our viewers, and she asked, why is there frequent urination with prostate issues?
It depends on if it's prostate cancer or if it's an enlarged prostate. If it's an enlarged prostate, basically the way the anatomy works is the bladder sits at the top, then the prostate's underneath the bladder. The urethra is this channel that runs through the middle. Well, as you age, the prostate bulges inward and it narrows that channel. So it makes it harder for the urine to empty out. So typically the reason why people urinate more frequently is because they never get empty. So they'll pee, they'll get out 40%, then they'll fill up faster, then they'll pee out another 40%. So if they're never emptying to 100%, they have to use the bathroom much more frequently.
Thank you. Are there any other questions? I've been trying to watch our live feed to see if there were any additional questions.
I might have missed this earlier. Is there something in addition to frequency and urgency that men should be cognizant of, such as pain or anything that might resemble, say, for example, a UTI?
Yeah, pain, burning, blood in the urination, painful ejaculation, blood in the semen. Anything like that could be symptoms that something's going on and that you should get checked out.
Well, Dr. Howard, I don't see any more questions from our audience, but I know you have taught me something today. So we definitely appreciate your expertise and your willingness to join us from the West Coast.
Yeah, you guys were talking about weather earlier. It's nice. Well, we actually got today, so
I'm not messing with you in that weather.
Okay.
Your
If you want to say it's weather, we don't want to hear it. It was 27 degrees when I woke up this morning, so we don't want to hear it.
California cold is 50.
It's cold.
That is cruel.
Oh, I remember.
So cruel.
Yeah. Well, we definitely appreciate you being here with us, Dr. Howard. We appreciate all that you have shared with our audience, and we hope everybody has a good night out there.
Thank you, Dr. Howard.
Thank you so much, Howard. So good to see you.
After your busy schedule today. Thank you.
It's been so long. Oh my gosh. Please keep in touch.
I will. Thank you so much for having me.
Absolutely. Have a good night, everyone.
Good night, ladies.
Bye.